Yeah.
See? Yeah.
Passionate.
Everyone should be able to hear you.
Okay, good morning, everyone. It's Janine Logan. Can you hear me? Those in the virtual world, in the nether world out there?
Yes, thank you. Hi.
Hi, okay, very good. So, as I said, we're recording this meeting, so your participation in the meeting is your consent to agree to the recording. So that's just housekeeping rules. And Janine Logan, for those of you who don't know me, Janine Logan. I have several titles, but for this one, I'm the director of the Long Island Health Collaborative, and I'm the director by virtue of being VP of Communications and Population Health for the Nassau Suffolk Hospital Council, which, since we lost the state grant funding right as the pandemic arrived, has been managing and supporting the continuance of this collaborative. So that's that. So I think we asked you to put your name and affiliation in the chat, but we'll also ask you in the virtual world to introduce yourselves. And can we call upon people? Are we going to see them? We'll see you in our Hollywood Squares display, and we'll call you and just, say hi, say your name and your organization quick. And if you want to put more about what you do, you can certainly put that in the chat and we'll capture it that way. Then we send this recording out to everyone
Yes, we'll post it on
and
our
the
website.
slides, and you'll see all the chat information. So Greta Garcon?
Good morning, everyone. Hi, I'm Greta Wharton. I am the Executive Director of the Long Island Coalition for the Homeless. I'm also a member of the Health Equity Task Force. Long Island Coalition for the Homeless oversees the Regional Continuum of Care, which is essentially a planning entity for homeless services and permanent housing throughout Nassau and Suffolk counties. Glad to be here.
Glad to see you, Greta. Trevor Cross, how are you? Have not seen you in many, many years. What's going on?
It has been so busy.
Yes.
Thank you very much. I'm Trevor Cross, of course, as Janine just said. I'm from Sun River Health, and the regional manager for Western Suffolk. And we community initiative department. And we basically provide healthcare, outpatient healthcare to every and anyone who needs it.
Excellent.
We have 12 sites all over Suffolk.
Trevor, can you send me your updated email information? I don't think I have it.
I will.
Well, maybe we do, or else he wouldn't have gotten.
Yeah,
the
you
notice.
should. Yeah, you should. You should be
He
on
wouldn't
there.
have gotten the notice. Okay. My dear friend, Dr. Linda Mermelstein, there she is. Just let her walk for us.
Hi, I'm Linda Mermelstein. I'm the Associate Director for Community Outreach and Engagement at Stony Brook Cancer Center, and I'm happy to be here. Thank you.
Karen Beck from Association for Mental Health and Wellness, right?
Yes, hi, good morning, everyone. Karen Beck, I'm the Director of Quality Improvement here at the Association for Mental Health and Wellness. And I'll be speaking a little bit in more detail about the programs and services we offer here for individuals in Suffolk County.
Thank you, Karen. Hi, Christine Duffy.
Hello, how are you?
Good.
I'm Chris Duffy from St. Mary's Healthcare System for Children. We do home care, and we also have a 124-bed post-acute skilled nursing facility in Bayside, Queens.
Oh, glad to have you.
Thank you.
Karen?
Might be correct.
No, it's Karen.
Oh,
Karen?
Hi, everybody. Hi, Janine. I guess I could just put this on for a second. I'm here with Alicia. We're both with Creating Healthy Schools and Communities at Western Suffolk BOCES. This is a New York State Department of Health funded grant, and we have 3 grants targeting Town of Babylon, Town of Islip, Town of Hempstead, and it's addressing physical activity and increased access to nourishing, affordable foods.
Thank you.
Nice to see everybody. Wish we were there.
Yeah, because you're missing out on the bagels and fruit.
I know, next time.
And some Danish, not the healthiest choice, but it's here nonetheless. And then there's Michelle, but I can't see the full last name. What is it?
Bontempi?
Bontempi. Hi, Michelle Bontempi.
Hi. Good morning. My name is Michelle Bontempi. I'm the Associate Program Manager for National Grid's Home Energy Affordability Team, otherwise known as HEAT. We perform home energy assessments for homeowners and renters across Long Island and help lower their gas bills and make the home more energy efficient. We do repairs and replacements on appliances as well, such as the hot water heater and boiler or furnace as well. So thank you.
Yeah, I might need to call you in. Save me some money.
I will certainly send information after this. Thank you.
Thank you for joining and for that important service you provide. Anastasia Shepers.
Good morning, everybody.
Good years.
Yes, it has been. I'm happy to join this morning to represent our team. We are the Breastfeeding Resiliency Engagement and Empowerment Team, Be Free, from Cohen Children's Medical Center, and we just started our new 5-year grant with the Department of Health, New York State, to promote and support parents and families to breastfeed. And our catchment areas, we have 2 new ones, Town of Hempstead, Town of Babylon, in addition to our previous 5-year grant, which was Town of Islip, Glen Cove, Southampton, Wyandanch, and the Shinnecock Nation. So happy to be here with everyone.
Sue-Ann Villano, again, long time no see. Put that camera on, Sue-Ann.
That's on. Give me 1 second.
She's doing it. She's
Here we go. Hi, everyone. Hope you can see us here. Can you see us now?
There you are, sort of. Oh, you're in
Yeah,
a
we line that
Okay.
came also. We're in our Manhattan office today, so sorry I'm not as savvy on the equipment that we have available to us, but it's great to be back at the table. Thanks for having us.
Okay. Zareen. She's
Oh, Zareen, you're on mute.
Unmute yourself, unmute her. Unmute her. Zareen. She's speaking. You're wasting all your breath. Zareen. Unmute. Unmute yourself.
There we go.
Go ahead. Zareen.
Oh.
I don't know what she's doing. Well, anyway, can you unmute her?
Yes, so
There she is. You were on mute all that time.
it's Zareen Bajwan. I apologize. I always close my mic as I receive a phone call. So I'm with Cornell Cooperative Extension, and nice seeing you, Janine, after a very long time. I've just been terribly busy with a lot of things going on. I am the Director of Community Education at Cornell Cooperative Extension. And we have the largest obesity prevention program for NASA and Suffolk, funded by USDA. And one of the programs that we provide is the SNAP education, which is a sister program to SNAP. And it is a free program for nutrition, health, and environmental change for both Suffolk and Nassau counties.
Excellent. SNAP might be in a little bit of jeopardy come Sunday.
I hope not. I really hope not, that there's common sense in our legislators.
Common sense? You ask too much. Good morning, Analia Trask.
Good morning, everyone. I'm Analia Trask. I am the program coordinator for the Cancer Prevention and Action Grant at Stony Brook Cancer Center in the Community Outreach and Engagement Office, and I'm happy to be here. Thank you.
Good. and see if I pronounce this correctly, Galal Ashkam.
Good morning. My name is Galal Al-Zokom. I'm the Director of Case Management at Pilgrim Psychiatric Center, Office of Mental Health. And our program does intensive case management for people who are high need for intensive case management, specifically around people who are mandated by the court as CBL or AOT clients.
Oh, okay. Good to have you
Thank you.
and welcome. Angela Cabrera? Sure if I'm saying these names right.
Hello, hi, good morning. I'm Angela Cabrera. I'm one of the associate project coordinators on the Be Free team with so I work with Anastasia and the rest of our team to recognize work sites, practices, and student community spaces to become breastfeeding friendly along Long Island. So nice to meet everyone.
And welcome, Kathleen Emmett.
Hi, everyone. I'm Kathleen Emmett. I am a nutritionist and the nutrition program manager at Island Harvest Food Bank and addressing food insecurity and nutrition insecurity in Nassau and Suffolk County.
Thank you. Glad to have Island Harvest represented. Samantha Klein.
Hi, everyone. Good morning. Sam Klein. I'm the Health Equity Alliance Coordinator with Health and Welfare Council of Long Island. Happy to be here.
Happy to have you here, Samantha. Jessipina Caravella. Hopefully I said that correctly.
Yes, you did. Hi, I'm Josepina. I work at Stony Brook Cancer Center, Office of Community Outreach and Engagement, and I am a health educator.
Nice to meet you and have you here again. Now let's see if I can say this name correctly. Rajiv Lajmi.
Yes, perfect.
Oh,
Thank you for having me. I'm Rajiv Lajmi. I direct the graduate program in applied health informatics at Stony Brook University.
oh, okay. So you're a data person.
Yes, we are. Yes.
All right. We might need to pick your brains a little at some point in time.
Absolutely.
Thomas McGinnis?
No, Matt Kinley. It's Thomas McKinley, Senior Executive of Business Relationships at Altix. How are you? Good this morning.
Oh, yeah, McGinley.
Matt Kinley, correct.
Oh, Thomas, we've met in the past.
Yeah, we've met many times. How are you?
Yeah, it just says Mac GI on the screen, so I wasn't sure if it
Oh,
was
okay.
you, but it was great to see you again. And then Adessa Watson from the Suffolk County Health Department. Hi there, Adessa.
How are you, Janine? Good morning, everyone. Deswa Watson. I'm the Director of the Office of Minority Health in the Suffolk County Health Department. So our focus is addressing health disparities and inequity, educating community and providers, as well as addressing access to care and access to culturally responsive care. We also sit on the MAC, which is a committee that looks at behavioral health and providing culturally responsive care in those fields as well.
Well, welcome again. Cynthia Friedman, also Suffolk County Department of Health, I believe.
Hi, yes, I'm the Director of Public Health for Suffolk County. I'm currently responsible for coordinating the composition of the CHACHIP.
Yes, we've spoken in the past.
Yes.
Yeah. Kelly DeVito.
Hi, yes, Kelly DeVito from Horizons Counseling and Education Center, outpatient substance use program that does treatment and prevention.
Hey, Kelly, you were often, I think the last couple of meetings you were here in person.
Yes. Yes.
So good to see you.
Good to see you.
Vanessa Moses.
Hi, good morning, everyone. Vanessa Moses from Family and Children's Association. I am the program coordinator for the Safe Senior Prevention Coalition, where we focus on substance misuse among the senior population. However, the organization as a whole focuses on everyone through the lifespan. So we offer everything from mental health care, substance misuse intervention, housing assistance. You can think of it, you name it, we probably have. Yeah, we probably have a program for it.
Children's Association out of Mineola, right? Isn't that
so yeah, we have so many offices. So there's one in Garden City. I'm actually out of the Hempstead office. but there are offices all over the place.
So a dear friend and colleague of mine recently began working there, Julie Robinson Tingay. I don't know if you've met her. She's working with you.
What department is she in?
She's in communications and
Oh, I don't know. I'll have to look for her and tell her
started
that I
last
met
week.
you.
She's fantastic. That's why I mentioned her name. So if you haven't had a chance to meet her yet, definitely meet her. She's phenomenal.
I will. Thank you for that.
Who else?
Anyone else virtually who we
We
missed? I think that's everyone, because I counted 20.
I could sit here all day and have conversations with everyone and talk about, we've all done so much work together through the years, and some of it's frustrating, as I've expressed many times. We don't get to those changes that we really hope to get to. Some of it's very rewarding too, and I kind of hang on to that, and I hope all of you do as well. So now we'll go around the room. We'll start here, and it's gonna be a little bit of a delay, but the camera's gonna follow you.
Okay, it'll reach.
So that it should reach, so that they can see you.
Yeah, because I can always stand doing it. I think I'm right at the cusp.
Should get her right.
Yeah. Yeah. Are you in there? I think I'm
Just cut off. I think you just cut off. There you are.
Perfect,
We
thank
see
you.
We see you.
Good morning, everybody. My name is Diana Loomis. I am the Regional Outreach Manager here in Long Island and Queens with Montanito and Affiliates. We're a national eating disorder treatment provider. So we offer anywhere from inpatient all the way down to IOP for adolescents and adults. And like I said, we're national, so we are scattered all over. We're very lucky in New York. I think we have about 6 or 7 program sites kind of scattered about. So happy to share more info if anybody is looking for that for their clients as well. Thank you.
Okay, thank you for joining us this morning.
Yes.
Hi, I'm Hannah O'Neill. I'm
me see
the
Hannah.
growth. I'm like on the end.
Where are you?
There you
There we
are.
go.
Hi, Hannah.
I'm Hannah O'Neill. I'm the program department intern with the Moore Foundation for Breast Health Education.
Sure, thank you. Welcome.
And I'm Eileen Pilateri from the Moore Foundation as well. I'm the program manager.
I'm Nadine Wilches, president and founder of My Dark Health, previously Mind Class, went through a little rebranding, name change. We have developed a new population health data-driven model for reducing the risks and rates of mental and behavioral health disorders in youth.
Excellent.
We are kicking off.
Probably need to hear more about that one.
I'm Brooke Oliveri, Manager of Communications, Health Outreach and Research for the Nassau Suffolk Hospital Council and Manager of the Long Island Health Collaborative. Work very closely with you.
And problem solver extraordinaire.
Oh, thank you.
Good morning, just in
Good
time
morning.
to introduce yourself.
Did I miss that?
No, you didn't.
No. My name's Cleopatra. I'm with PBMC, Peconic Bay Medical Center.
Nice to meet you.
Thank you. Nice to be here. I'm sorry I'm late.
That's okay.
I did kind of get lost, but Dijon knows. Dijon is my colleague. We work together.
Okay.
She's stuck with me. And basically, we more or less did the same thing, except I have a focus with lung cancer and breast and prostate, but educating the communities about the importance of early detection. Oh, what a question.
That's okay. Take- Now that you've introduced yourself, there's refreshments over there, coffee. You can go get that now.
Okay, thank
Oh,
you.
We're happy to have you here.
Hello, I'm Dijon Strange, and I'm from Peconic Bay Cancer Services Program of Suffolk County, and Cleo is my partner in crime, and I focus on breast, cervical, colon, and I do help with her with prostate and lung.
Is that partly funded by the state? Is that the
Yes, New
state,
York
for
State
the New
Department
York
of
State
Health.
Cancer Prevention Services?
Yes. The lung cancer unfortunately isn't yet, but it's something that's work in progress. And as of right now, we basically focus, we can only focus on individuals that are 50 and above that do have health insurance. And most health insurances are on board in order to get the early detection screening.
Okay, good. That's good to hear.
Hi, everyone. Erica Clark, Community Relations Representative for Stony Brook Medicine.
And last but not least.
Hi, everybody. I'm Maria McHugh, and I am the Health Educator Supervisor on the Comprehensive Adolescent Pregnancy Prevention Grant at Stony Brook. We work mostly with young people ages 13 to 21, but we're also working with their parents and with the community. And recently, I just want to say, we added a new component to our programming, which addresses issues that the teens feel are important in their community. And they are the ones that create projects and go out and outreach in the community. So I'm very excited about that because I'm like 66 and I'm tired of talking about sex.
Oh, what a
I've
way.
had enough.
That's excellent. I mean, to get the students involved, it's right, that buy-in from the communities with which, or with whom you are working is so important. And I just read too, I don't know if it was a national statistics or if it was, I think it was national, that the teen pregnancy rate is starting to, yeah, we're making a little bit of a reverse.
As well as the STIs.
Yeah, and it has a lot to do, I think, with some of the policies and legislation that's been put in place throughout the country related to contraception and reproductive health and all that entails. So that's like one step forward, two steps back. So when I read something like that, it kind of like chips away at my enthusiasm a little bit, but
I think that personally, not looking at just the statistics, but
Yeah.
personally, because I work with the team
Yeah.
so much, there's a real lack of, I don't know how to explain it, but there's no foundation for right, wrong, good, bad.
no values.
No
like
values.
They have no
I guess
values.
that's the best way to put it.
Right, you know, because years ago, if that, I know I got caught in a situation like that, my parents probably would have cut me off at the knees, you know, that's the way it was. Thankfully, that didn't happen. There's also a lot of sex education that's being pulled out of schools or being watered down, right? Through in different, in different,
information
or
is
incorrect
being-
in different states, right? I don't think it's New York so much, but there's other states. But we're really focused on New York and Long Island, so I'm going off on a little bit of a
We don't
tangent.
have that many schools on Long Island that are allowing our programs in.
Really?
Yeah, so that's another issue, and
Ah.
because the health teachers are taking that, you know, that information and giving it out, and they're not doing it properly. Because I've sat there and I've watched, you know,
Ah.
listened to some of the teachers, and they don't have the right information.
So
And they
there's,
certainly don't have the most updated
yeah.
information. So
Mm.
that's an issue.
All right, well, glad you're here. Why this happens to me. So now we all know who we are. Where are we up to? So we're gonna talk about core clusters, and if you wanna go over from here for a little bit.
So just a little update, as some of you may not know, we formed some subgroups that we are calling core clusters among our members. Thank you to everyone here in this room and everyone attending virtually who has participated so far. As you can see, we have three main groups that we've formed around these three topics: mental health, chronic disease, and cultural competency, health literacy. So we have had our initial meetings for these groups, but we are welcoming all participants. Anyone who would like to participate is welcome to, and we would love to have you. At our last meetings, we did previously discuss a monthly cadence. I think we are going to move to a bi-monthly cadence for now. And we're going to be sending out a doodle poll in the next few days to everyone who participated in the kickoff meetings to determine our next meeting date. And anyone who would like to join us, please feel free, shoot me an email. We would love to have you.
Yeah, and the core clusters, we call them the core clusters, which is, they're really just work groups. But using some psychology, I thought saying core clusters would not have the connotation that you have to actually do work, which you really don't have to do a lot of work. We follow the collective impact model, and we are the backbone and providing the administrative support as best we can. So that's why they're called core clusters. And we did a survey the participants, the collaborative participants, to find out what they were most interested in, and these were the top three areas. Chronic disease, huge, like broad bucket of issues. It's always is at the top, even when we do our surveys, right?
Yes, and of course,
To the
these
community.
topics are very broad, which part of what we hope to do in our subsequent meetings is kind of narrow the focus to a tangible product at the end that we can all work toward together.
Right.
And, collectively
Right,
achieve.
we don't just want to meet, we want to come out with a policy recommendation and then some action steps or an intervention. We don't want to use evidence-based interventions, so maybe tweaking an evidence-based intervention that we feel a particular community in the chronic disease space, maybe it's an increase in type 2 diabetes diagnoses among a younger population, like 25 to 35, and we feel like, we want to attack that before it gets worse. I don't know, just thinking out loud. And then in mental health, we all know the mental health crisis that we're in. We don't have enough providers. There's work on state and federal level in terms of policy and legislation to try and solve that. I kind of been hearing that for years, and money comes in, programs start, money it goes away, programs stop, so I'm not quite sure. But I do know, and my colleague here at the hospital council had a conversation with her, our chief operating officer, just this past week. And I have to get more information on it, and I think for the mental health group, this might be something good to work on. I think it's federal monies that are looking to almost help regions develop, shall I say, like a line that we can follow from those who are in the hospital and then discharging to community services, whatever those community services might be, and involving an EHR that is applicable to everyone to use both inside and outside the hospital. I'm not quite sure I'm getting it right, but she did talk to me about it. It's a project that the Nassau Suffolk Hospital Council is, I believe we're going to flesh it out for our 2024 work plan. And she talked about bringing together behavioral health committee, and I said, wait a minute, don't bring together a behavioral health committee. I have a group already that is mental health. We call them core clusters. I said, and I think this might be something really good for them to work on, and it would involve actually bringing in more hospital participation, which is easy enough to do. We have Family and Children's Association represented, Family Service League, some of the other smaller organizations that work in this space as well. So I'll have more to talk about that in December. It's just something that was brought to my attention just a couple of days ago, and I'm not even sure if I totally understand what she was hoping to do, but it's like a perfect fit. And then cultural competency, you want to talk about that?
Yeah, so I guess just kind of an update about what we've discussed in the group so far. So we have kind of discussed actionable steps in each individual group, specifically for CCHL. We did have a program previously that we discussed kind of looking at before our next meeting to kind of do a SWOT almost, to look at what we think we could improve based on what's on our site already. So I know we've had these initial meetings. I will, in all of our next communications, I'll send kind of a summary. So don't be intimidated if you missed the first one. You can always review the recordings online there. But yeah, that's one of the first steps for CCHL.
Yeah, and what Brooke is referring to is when the collaborative had funding from the state, we were able to do a lot of really great work. Feel we continue to do great work, but not to the extent that we had been able to do. And we developed a cultural competency health literacy training program in connection with the district, the two performing provider systems, which was really based on a train the trainer model. And it was a 7-hour course. It was in person. You would go in and you'd be trained, and then you'd be like a master trainer, and then you could go back to your organization and train people. So, and then there was some static online training that you could do, and I took it, it still works, and get a certificate. But so I think that the cultural competency health literacy core cluster can take a look at what we've already done, right? And see, is it meeting health equity standards now, right? That we're very focused on. And when we think of health equity, we've got Joint Commission, health equity standards that hospitals now have to meet. The Centers for Medicare and Medicaid Services has also added some health equity measures. The National Quality Forum, NCQA, National Quality Forum Association, they have 4 practices, primary care practices, that want to become NCQA certified, right? So they get a little bump up in reimbursement. They also now have a certification or an accreditation. So with that in mind, and one of my tasks is trying to crosswalk all that together and be able to say, well, these are the maybe even the Institution for Healthcare Improvement has something, I don't know. List them out and see if this cultural competency health literacy, the way it's designed right now, checks some of the boxes for organizations that might need accreditation or might want certification or whatever it might be. So I thought that would be an excellent project for the cultural competency health literacy group to wrap their hands around. And it's something to start with. And Brooke has also provided everyone with logic models, inputs, outputs. You know, in public health, we like to box ourselves into these.
Have a guiding framework.
I'm a
Give it
little
some
more,
structure, right?
I'm a little more ragged edges, and I'm kind of, I don't want to say loosey-goosey, but I kind of like to think a little bit out of the box and not be restricted to those some of those models that are in place. But be that as it may, it does help. It gives you structure. It keeps us from just having a meeting and just talking about the problem and not coming into solution. So that's what I have to add to that.
Yeah. I think that's it for the cluster.
So the
update.
clusters.
Next here.
Oh, Karen Beck.
Hi, good morning.
So you want to just tell why we're doing it? Brooke is gonna I'm gonna go get another glass of orange juice, and then Brooke's gonna.
So as you might remember from our last meeting, we wanted to introduce these Long Island Health Collaborative member spotlights, just giving a random member that we choose, 5 minutes to kind of discuss what it is that their organization does, some of the great resources that they have to offer. That is feedback that we've gotten from a lot of members, is that, there are all these great things out there, but it's tough to know about all of them. So we just thought this was a small way that we could allow members a little soapbox to kind of share their current offerings. So Karen Beck is here to speak a little bit about the Association for Mental Health and Wellness. Karen, please take it away.
Yes. Hi, good morning. Thank you, Janine and Brooke, for taking the opportunity to highlight the Association for Mental Health and Wellness this month in our monthly meeting. My name is Karen Beck. I'm the Director of Quality Improvement here at the agency, and I'm going to do my best to highlight in about 5 minutes all of the amazing services that we provide here. Our mission really is to provide evidence-based practices and provide education and resources to residents within Suffolk County. On the right-hand side of the slide is a very brief description of the wide range of services that we offer. Our pros and core programs offer psychiatric rehabilitation services to individuals to help them identify, choose, and maintain their desired life roles, whether that be in the areas of living, learning, working, or socializing. Our PROS programs specifically provide these services on site at 2 of our program locations, one here in Ronkonkoma, and then we have a second program location in Riverhead. And then our core program provides these services to individuals in their chosen settings. So whether that be in their homes or other community-based locations, pretty much meeting individuals where they are at in the community to be able to provide these services. Our adult and children's care management programs also provide services to individuals, adults, and children in the community, and are really directed at aiming to help them meet both their health care and their social needs. So our case management programs work with, children and adults in, again, their chosen settings in the community, and really work to coordinate services with their other providers and schools, community-based organizations, physical health care, and their social needs. We have a very extensive community impact program that provides a lot of different trainings. We have trainings that are focused on mental health and anti-stigma education. We also have youth and mental health first aid trainings, which are really directed at helping people to maybe identify signs of people who may be experiencing crisis and help connect them to services. For the youth mental health first aid trainings, this is really aimed at providing these services and connection to help for youth and adolescents. And for the adult, it's working with the adult population. And these trainings really are aimed at anyone can take them. They're available for employers, hospital staff, police officers, first responders, faith leaders, and other community-based organizations. So they're really wonderful trainings that we provide. And then we also have a lot of different workshops and training opportunities for individuals in professional development to also obtain continuing education credits. So that is just a small fraction of what's available through our community impact program. We also have a community helpline open for anybody who may need information and or resources or referrals. They're able to contact us at our community helpline. And we also offer a number of support groups for friends and families for individuals who are diagnosed with mental illness, as well as peer support group services. And we also have a number of peer programs here at the agency. We provide supporting housing services for veterans and individuals living with mental illness under our OMH funded programs. And we also have food pantries located at both of our program sites here at Ronkonkoma, as well as in Riverhead. We have a healing garden. It's a wonderful space that we have located near our program that's maintained and worked by Master Gardener, as well as our program recipients who come here. And then the fresh fruits and vegetables that they harvest is donated to our food pantries. So we also have a soup kitchen, which we sponsor every week here at our Ronkonkoma location. It's sponsored by the Ronkonkoma Rotary Club, and it's open to anybody who's in need of a hot meal. There is live music. It's a really wonderful atmosphere for somebody who may need a hot meal or looking to socialize, looking to get help, maybe need some support from our food pantries. They could come and have a lovely meal and listen to live music and be able to socialize and get the support and services they need. So I don't know if I got all that done in 5 minutes, but it's a very brief overview of our services.
Anyone have any questions or for Karen?
Any questions about maybe some of the specific services we provide or trainings or even some of the eligibility requirements for our programs, please do feel free to reach out. You'll see on the slide, there's Colleen Merlot's information, our Chief Executive Officer, as well as Kim Bauer, the Executive Assistant, and they're able to point you in the right direction based on any questions you may have.
Karen, I have a question.
Mhm.
When I was speaking earlier about the cluster, the
Yes.
mental health cluster,
Uh-huh.
and this project that I believe is going to take shape under the council's direction, in the beginning of next year.
Mhm.
And it has to do with hospitals and discharging individuals to appropriate settings. These programs, like the PROS and core programs, are they all like referral programs, or can somebody just call up and say, hey, I want to get involved in this program? Are they referral programs that, I think they are, but.
Yes, they are referral programs. So basically, we receive referrals from community-based providers, from hospitals, other settings where individuals may be discharged and looking to connect to supportive services in the community, or anybody who is interested in services for themselves or maybe a friend or a family member can also call and inquire about our programs, and we're able to kind of work with them around you know, what would best meet their needs.
Okay. All right, so again, it's making that connection, because I work with hospitals and represent hospitals, and I know hospitals oftentimes have a very hard time finding the appropriate setting to discharge a particular patient, so, and there's all levels of acuity that patients have. And lastly, do you welcome volunteers to work in your garden?
We do have, I know we do have a lot of volunteers that come and help us for a lot of our events and services. You know, that's something I can ask about. I do know that we have a master gardener who does kind of maintain the garden. And again, our members play a real integral role in being able to maintain that and really just work on like skill building and kind of working and participating in the garden. But I know that we are definitely always looking for volunteers, you know, to help with a lot of our community-based events. So if anybody has any questions or is looking to connect, please do reach out and we can kind of make that connection.
I mean, I think it's a great idea, a healing garden. There's nothing like working in nature for the mind and the body. Greta, is it Garton said she has a garden in Amityville where they accept volunteers.
Yeah, I mean, it's really just, it's wonderful to be able to see that garden and then see the contributions that we're able to kind of bring into our food pantry as a result of that garden. So, you know, it's something we're very proud of, and it definitely is, you know, speaking to what you shared about the healing practices of just being able to kind of get your hands dirty and work with nature. So, yeah.
Okay. Anyone have questions in the virtual component of this for Karen? I you know, you'll get these slides, so you'll get her contact information, but I think you really did a good job of sticking to the compressed timeline. And I thank you. And as I said, we randomly look and select some organizations, so you never know, could be you next, so.
Great, thank you. I know it's very challenging. You want to be able to talk about all of the amazing work you do and to kind of fit it into 5 minutes, but you know, the bullets are there and they're pretty compact in terms of the type of services we provide. And again, any questions, please do reach out.
Thank you, Karen. Thank you.
Thank you.
And we had an individual who arrived in our in-person meeting space, and we'd love to have you introduce yourself. And
Hi everybody. I'm sorry, I had a.
That's okay.
Oh, it's okay. So my name is Elisa Papaladze. I'm a social worker and a geriatric care manager. I used to work for Catholic Charities and seen the families struggling to place home care, and I opened my own small company that is it's a registry. That what it means that like you were saying, discharge patient, a lot of rehabs love me because if the family want a caregiver, and they can't afford some other prices, we can negotiate, I can match and find the right caregivers for the families. Most of my caregivers are originated from Georgia, Russia, Ukraine. Like me, I'm from Georgia, and they do speak Italian, Greek, French, German, Polish. So when the patients have mental, like Alzheimer's, and they went back to their native language, and they need somebody specifically who speaks their language, I can help them with that. And price-wise, if they're on Medicaid, we can go through CDPAP. Some long-term care insurances will accept independent care providers. We can help them with that. So that's my role, and I have a daughter that helps me. It's like mother-daughter company.
Nice.
And geriatric care management I do in the city, not here, but here I help to find if you need a caregiver and you have hard time to discharge the patients. And most of my caregivers are immigrants. And this is very important because Hamilton says immigrants get the job done.
It's true. This is a country built on immigrant
exactly.
labor, right?
Yes, exactly. And a lot of time they ask me, why did I came to this country 24 years ago, actually, and I had $300 in my pocket, one suitcase, a single mother, 2 kids, and look where I am. This is a country of big dreams. And why I got into this elder care field, because I grew up in Caucasus Mountains, like in Georgia, and in Europe they say that the people who live in Caucasus Mountains, it's mostly centennials. And I had a direct relative, great-grandfather, who lived over 130. I actually found the articles about him. Yeah. And they were, and he was, and I want to, why I mentioned, I want to share with you this morning the secret of longevity and healthy,
Please do.
aging. Yeah, people interview. I hope it's not, do I have time or?
Sure, this is what we like this discussion.
Okay. Yeah, so he would say that 3 things are very, very important. First, he would say walk a lot. Those times, it was my great-grandfather in early 20th century, there was no big transportation.
so
He
you
lived in a village, fresh air, walking a lot. So, and it's true, walking and exercise is important. And second, he would say, he said that he drank every night at dinner a glass of red wine.
I like that part.
Yeah. And actually Harvard Medicine, when I read articles, they discovered that it's good for cholesterol and lowers down the cholesterol. But 1 glass is red wine.
Red,
That's
red,
red.
okay.
Yes. And the third thing, you might laugh at, but you have to eat yogurt every night, go into bed.
But
Yogurt.
not that flavored.
No,
sugar
not
yogurt,
flavored,
plain
nothing
yogurt.
plain yogurt. And whenever I mention and I tell this story, some generation, they said that, oh, I remember there was a Denon commercial. The old man sitting, I don't know, in 1972, they stopped it, but there was an old man sitting in Caucasus Mountains, and I did research, and
There it was.
my grandfather sitting there, like old, because they filmed him a lot of times. He was a long-lived person, and yeah.
That's great
the
information.
And he also mentioned, he also said that throughout his life, he discovered one thing, that he measured the distance between truth and lie. Do you know the distance between truth and lie? It's very simple.
What is it?
It is like 4 fingers, like this is the distance. You know why? He said, put your fingers, 4 fingers here, said, whatever you hear, it's a lie, but whatever you see, it's a truth. So if you want to see the truth, you have a client call me, I get you a nice age.
Empirical evidence. Okay.
Thank you. It was
Excellent.
really
That was
lovely.
great information.
And thank you
know,
for
and,
having me.
So I'll digress just a little, but that kind of dovetails a little bit on blue zones. Have people heard about the blue zones? Yes. You've heard about the blue zones, right? Netflix just had a great 4-part series on blue zones. And blue zones are areas throughout the world where there are a higher percentage of centenarians, people living over 100. And it comes down to exercise.
Yeah.
And a lot of it is walking, and the collaborative itself began on the premise of walking as a means of simple but effective exercise. So that's great. That ties back into that. And nutrition, and again, the exercise, nutrition, diet, that's how we combat chronic disease, even mental health, right? Helps you with your mental health. So nutrition, and they were some of the areas, if I recall, and I have to watch the series again, it was fascinating. Okinawa, Japan. There was a woman, over 100 chopping wood with an axe. A small area in Costa Rica in the mountains. There was a gentleman, 105 years old, jumping on a horse and rallying the cattle. What do you do? Herding the cattle. And the fact that he was so agile that they went to the capital to check his birth certificate to believe he was really 105. So there was that. Sardinia, again, and that's kind of like the Mediterranean diet they're following, and most of them have very little meat in their diets. And another one was Singapore, which was interesting. And one location in the United States, Loma Linda, California, and it was connected to the Seventh-day Adventists who incorporate health practices like lifestyle, exercise, eating, proper eating into their religion. So they had a good number of centenarians. And I just thought it was fascinating, and I want to do a little more research on that, but and then also supports, social support. They all had community social supports. They took care. If one was not well, the group got together and took care of them, right? They weren't living in isolation. They didn't really have technology, right? They were living off, we all can't live off the land, let's be realistic, but they had to make do with what was there in front of them. And these were more regions that, like Sardinia was a little bit more remote. The area in Costa Rica was a little more remote. It wasn't the main tourist attraction areas along the coast, because there they had the fast food restaurants and all the other problems that we get. But somebody wanted to say something?
Oh, no, I was gonna say, I think the one that was really relevant for here is the community.
The community,
support
right?
from the community you mentioned.
Right, I think in Okinawa, they called them the Maui, right? So it was, I think it was them, women who would gather and it was just normal. They would come to another person's house and bring them food. It was phenomenal. And it was a journalist who researched this for like over 20 years. He got some kind of funding, I believe, from the government here to find a community that would be a test pilot to become a blue zone, and it was somewhere in Michigan. I can't remember all the details. And after a year or two, everybody got on board. It was multi-sector, right? Socio-ecological approach. The schools and the faith-based and businesses all got on board. They saw drops in, I think some people were off medications. They did see drops in obesity rates. I mean, it worked. So my mind is like, why do we not replicate that? Anyway, I digress, as usual. But it was fascinating. If you get Netflix, you should watch it. Fascinating.
Switching gears.
I like the guy who jumped on the horse at 105 and rode off into the sunset. I mean, that was like, holy, wow, what are we up to? Oh, the waiver. Okay. And
We'll go through.
What? We're in good time.
Yeah, we're good.
Yeah. So you're all familiar with the the Medicaid 1115 waiver. The state has submitted to the federal government because Medicaid is a joint federal state administered program. we get monies from the federal government for our Medicaid program. States are allowed to design their own Medicaid programs, and they do that through what's called an 1115 waiver process. So, and there've been a number of them through the years, last one being DSRIP. That was an 1115 waiver process. And the general idea is that we, the state, are going to redesign the Medicaid program so that it becomes more efficient, and we're going to save you, federal government, monies, the 50% matching monies that you give us. So that's the premise of it. So this 1115 waiver has been percolating for a while, ever since DSRIP ended 3-4 years ago, whatever that was. And it's a long process, a long negotiation process, right? State has a concept paper, conception of what they think the waiver, what they want in the waiver, they submit to the federal government, CMS then looks at it, then they go back and forth in negotiations, right? What should be in, what should be out. And last we heard from the DOH is that by mid-October, we would have the completed waiver, right? They would come to agreement on pieces that were in there. You might have heard a year or two ago, certain components of what they were hoping to do, like those heroes, I don't know what it stands for, but it was a hero, a health equity regional organization, that's what it was. Some emphasis on social justice and the prison populations, and that was all in there. So some of those items are out, but anyway, so by mid-October, we're supposed to hear. Now, with the government shutdown looming, which I just heard on my way in the car, is more likely than not, that's gonna slow things down. So we'll see if by mid-October we will actually get that. And I think they were saying to implement it by January. There's no way a program like this would be implemented that quickly, but we'll see. So what do we know? So the waiver, what we originally asked for was reduced from 5 years to 3.5 years, right? So the CMS said, no, we're not giving you a 5-year waiver, it's gonna be 3.5 years. So that's a change. The budget that we asked for 13.5 billion. No, CMS says that that's not gonna be that much money, it's gonna be between 8 and 8.5 billion. Okay. So what the agreement we've thus far have reached are social care networks. They were formerly called social determinant of health networks, that will be more involved, because I think their role in solving the social determinant of health needs that affect clinical outcomes has been very much ingrained now in both the medical community and certainly the public health community. So we'll see what they actually look like. There'll be some workforce investments, because we all know very hard to get all levels of healthcare workers. And then we're gonna support, they wanna support the primary care delivery system model, which makes sense. That's the conceptual agreement that I have in place right now. These are just highlights. Now, what they're still negotiating on is the stabilizing the safety net hospitals, right? And making sure that there's health equity accountability within hospitals, I guess. I mean, it is there, but I'm not quite sure what that means. Maybe some kind of reports or whatever it might be to prove, probably not the best word, that you are attending to those individuals that are experiencing health disparities. Hospitals and healthcare providers do, but I'm not quite sure what that means. So I probably shouldn't comment on it. But anyway, and then the health equity regional organizations, the heroes, they thought that they were going to be regionally based originally, but now it looks like it's going to be statewide. And almost, I think that the state will maybe take on, and I'm not 100% sure about this, but maybe take on more of a data coordination role in that respect as well. And then what's been totally dropped from the waiver were those target and reach services for the criminal justice population. So they were looking at those prison populations and transition out of prison and into civilian life, but and investments in digital health and telehealth infrastructure. So that's a little interesting, given that telehealth just blossomed during the pandemic, but I don't know all the details behind that. But this is a high-level update that I wanted to share with everyone, and we're keeping here at the Nassau Suffolk Hospital Council and through the collaborative close watch on this, so anything I learn, I'll pass them along. Questions about this?
Janine, do you have a contact there that you are speaking with about that?
At the Healthcare Association of New York State, which is our parent company, for want of a better explanation, there is an individual who is kind of like trying to be the guru for this, so.
Okay.
Yeah, so
Yeah,
that's
I'd
where I
be
get.
curious to find out more about those investments in digital health and see.
Yeah, I can find that out for you.
Okay, yeah, thank you.
What's next?
Let's refresh about that. All right, yeah, so this is something we've kind of been talking about for a few meetings now. So we are working on refreshing the website in conjunction with the company that currently hosts it for us right now. So still a work in progress. We are doing some improvements on our end, and then there are some specific ones they're going to be doing on their end. So some of those include a streamlined navigation bar that's going to make it a lot more easy, more intuitive to access the resources that you want to on the website. We previously had this data assistant, which some of you might be familiar with. Its purpose was to kind of segment the data resources, but we've found it kind of gets more in the way than helps. So we're going to eliminate that so you can access the data resources page right away instead of going through that assistant. We are going to add summaries about each member to the directory to better guide you to a connection at an organization that you might want to collaborate with. And we are going to eliminate some of those extraneous pages that are no longer in use that are kind of cluttering up the site right now.
Right.
That was it.
Right, wait, I feel like I'm
No,
always
please.
interrupting. Like way back when we began, the collaborative began, which I thought was gonna be, I thought we were gonna be a temporary coalition, but lo and behold, here we are 10 years ago, 10 years down the road. But as I said, we all embraced walking, right? We knew that the best way to attack chronic disease was physical activity and nutrition, diet, and all of that. So we all embraced walking because it's simple to do. Most people can do it. You just need a pair of sneakers, not even. You can walk with flip-flops if you want to. I've done it. Probably not the best thing to do, but I have. And all these diverse organizations, right, who many of them are competitors around the table, right? For instance, hospitals really all compete with one another for the most part. They said, yeah, we can do that. So we developed, the collaborative did, a health education program called Are You Ready Feet? And the idea was to promote walking each of the organizations to their constituents in whatever way they would. And we developed a portal where people could go in. It was de-identified, track their steps or the minutes they walked. I mean, and we worked with schools. We developed specialized landing pages that once, like a 5th grade could be in competition against the 6th grade at different schools. I mean, we put a lot of effort and time into it, but it just didn't, we got some involvement, but it just didn't take off. It was not connected to Fitbit technology and those other technologies because that was just cost prohibitive. We couldn't do that. So it required you manually to go into your, sign up, go into your portal and enter your info. We had leaderboards and all of that stuff. So we really did have great ambition, and we thought, we even tried to get the 2 county health commissioners at the time to lead a contest between the 2 counties, but that didn't work. So long story short, Are You Ready Feet is gone, but we still hold fast to the premise of walking. And there's a lot of evidence out there, right, that says walking, no matter how fast or slow you go, you will get health benefits if you do that, both mental and physical. So that's one of the changes that you'll see. That's going.
Yeah.
As much as I hate to see it go, it has to go.
And like, for example, that was before my time, like
That was
our
before.
cultural competency program was before my time, so thank you for always providing the historical
The
knowledge.
historical context and, yeah, I mean, and we had a larger staff at that point. I mean, two people could not have done all of this. So we had a larger staff at the time. And the individual who really was responsible for developing the cultural competency health literacy was Sarah Ravenhall. Many of you may remember her, who has since gone on to become the executive director of the New York State Association for County Health Officials. So, really bright person. She's in a great spot. Hated to see her go, but I'd like to take credit that I trained her well. And she actually was here at she came down at the last collaborative meeting and did a presentation. So she really was the mastermind behind developing that, so. So we had a lot of great talent. We had great data analysts on board. We lost them. Northwell stole one of ours.
Sorry.
Stony Brook stole some people, but then nonetheless, here we are, and we do the best we can. It's a great infrastructure. It's probably one of the most organized, diverse coalitions in the state that is still running and being productive. So that's to everyone's credit who keeps participating. I thank you for that. Shut up.
Stop.
Oh, I have to give to Gab. I'm Irish. What can I say? This is you.
Yeah, so just wanted to bring everyone's attention back to our community health assessment survey while we're meeting today. December will be here before we know it.
Yep.
So we are putting a lot of effort behind gaining as many responses to our survey as possible before the end of the year. We have the links there, and we're also currently boosting the links on social media. You might have seen that ad over there to the right that we've been running. Historically, it has really helped us to gain more responses than in previous years. So we're really hoping for the same result. I just want to remind you all, we do have a toolkit in Google Drive that gives you paper versions of the surveys, the links, drafted social media posts that you can customize with your own organization name, some printable QR code signs in case you do any in-person events where you might want to bring that, or the printed surveys, and just some ideas about where else you might be able to distribute the survey, because of course, the more responses, the more robust the data, and the more hands we have on deck with distributing the survey, the more responses we'll hopefully get. So
yeah, and that survey dates back again to about 10 years ago when a small group got together and designed questions and drew from evidence-based other, looking at what the CDC had and some other evidence-based surveys. And that's the survey that's been in place, so it's allowed us to look at trends over time. We really amassed, I don't know how many at this point.
it's definitely over 15,000.
Like, yeah, it's like close to
Total over the
17,
years.
18,000, which is a lot of surveys. However, during the pandemic, it was hard to get people to complete the surveys. One, because we depend upon our collaborative participants when they're holding programs or going out into the community doing teaching. You can bring a paper-based copy. We'd rather it be a Survey Monkey link because it's easier for us, but that's okay. And it would be say burden, but we would strongly encourage that you would take these and get your constituents to fill them out, because the more data we have, the richer it is, the more response we have, the richer it is. It's kind of been dwindling a little, and that frightens me, which is why I was able to find some money to put into boosting, which is why I bring it up at every collaborative meeting. And this graphic that's up there, I'll just give you a background about how we came up with it. So I'm always trying to think of, because it's so cluttered, social media channels are so cluttered. I'm always trying to think of something that would catch attention. So I think, what does it say up there?
This isn't just a
pile of
of
papers. There's a subliminal message there. This isn't just another pile of, you know what I mean? So it's not just another pile of papers, right? It's an important pile of papers. It's your voice, and very hard to get people to take surveys. I see them, they come across my email and I'm like, take this survey, and I have no time for that. Delete, gone, right? So sometimes I stop myself and say, no, I should practice what I preach and take this organization survey. So we ask, it's in printed form. You can hand it, it's an anonymous, you can hand it out and then send a batch to us and we will input it. If you have any electronic newsletters, you can pop in the link to take the survey. If you haven't taken the survey yourself, please take the survey, which I also teach community health at Farmingdale, so I try and get students there to take the survey so that I get a younger audience, right? Don't know, oftentimes it's just that older audience because they're the ones with the chronic diseases for the most part. So anything you can do to get that survey in the hands of anyone who's over 18 would be appreciated. Anastasia, you have your hand raised.
Yeah, how will these surveys how will the results ultimately be used?
So the results are used for the most part by the hospitals and by the county when they're putting together their community health needs assessment. But community-based organizations and any organization, because it is on our website in a PowerPoint, Excel-driven PowerPoint platform that anybody can go in and use, you can make your own customized reports based on zip codes, right? It's all broken down by zip code. There's demographic information. It's really a survey that looks at an individual and community's perceptions of health, health barriers, health needs, social determinants of health, all of that. So that's how it's used. I do know that Northwell, with the Greater New York Hospital Association for this last round of its community health needs assessment planning, did work with Greater New York Hospital Association to design a survey. I haven't seen the actual I think it's longer than our survey, to drive their community health needs assessment. So in some respects, what we're doing is kind of stepping on one another's toes, right? So you can't survey people to death but our survey, theirs, I'm not sure, I think it's just used to fuel that particular end product, that CHNA and the community service plan. Ours is sent out on an ongoing basis and we analyze it every year. And we see changes, trends over time. But for the most part, chronic diseases and mental health is always rising to the top. So I don't know, does that answer your question?
Yes, definitely. Thank you.
Yeah, so you're aware of what Northwell did, right? With
Yes.
their massive push, but they had more money behind them and they had more people behind them to get it done. So, but I don't know if they're gonna do it on an ongoing basis like ours. Ours is always out there, right? So it's always, we used to analyze it twice a year, but when I lost funding, I had to go down to once a year. If I could do it twice a year again, I think that would be beneficial and a little bit of a differentiated from other surveys that might be out there, but we'll have to see. If I can pay the budget, I will.
I would just like to say that I think it's important because it sets the agenda for the hospitals and the county health departments and other organizations as to what the major important things are in our region to focus on for the, from the prevention agenda. So it's really actually quite an important survey. I mean, I know we're going to use it in our application to the National Cancer Institute. It's keeping a tab on what's important to people in the community. And it's really a vital instrument, actually. So
Thank you, Linda. And Linda herself, in the Cancer Services Center there, had a survey that she distributed, but it was very specific to cancer services. So that is that will augment what we do because ours is more broad-based. But I just want to emphasize again that any organization, you can use this. Linda said she's using it for their application. You can use this to get the data that you might need for an application of some sort, if you're a community-based organization. And if you're not quite sure how to manipulate on our site, the power pivot. We have a rudimentary knowledge. We're not the analysts, but we have a rudimentary knowledge, and we could always kind of walk you through it and help you pull out what you need. You get nice charts and graphs and pop that right into your application. And it's very local based, zip code based information, which is kind of hard to get. Okay.
Yep, so these links will be available in the slides when we post them, and in the summary, they will be linked, so.
Yeah.
And just some items we always want to bring your attention to. We have our bi-weekly email blast, collaborative communications. Please send me all of your jobs, events, other resources, anything you might want to distribute to our membership. Our events calendar is always available for your use. You can add events yourself at this link here. We approve them right away. And of course, Walk with a Doc, Walk Safe with a Doc are our community walking events in conjunction with the New York Coalition for Transportation Safety. As some of you might know, pedestrian injury and fatality on Long Island is especially prevalent. So that's kind of a way that we combine both of those missions to promote walking, as a way to improve our health and walking safely to avoid those injuries and fatalities.
And Dr. Mermel
Stein.
Not Steen, Stein. I'm never gonna get this straight. As I said, she led one of our was it a walk safe or a walk?
It was a walk with a dog in a park.
Walk with a dog in a local park in conjunction with AARP, right? AARP was there.
Yes.
And we will do this with any organization because we are one of the Walk with a Dog chapters. It's an international organization, but we pay a fee, a licensing fee, to be a Walk with a Dog chapter. And if you have if you're an organization, you want to hold a walk, let us know, and we do all the background work, right, Linda? We just need a dog to show up and lead the walk, which Linda did on Memorial Day weekend.
yes, but I had support from Annalee of Trask for Cancer Prevention and Action Program.
I'm sorry, Annalee, I keep forgetting about you. Yes. And the doc you get some free health information, and then you get to go on a walk.
It's a lot of fun.
Yeah.
What's the average participation in an event like that?
It's like 10 to 15 people. It's not, of course, I'd love to see hundreds of people, but not everybody wants to go for a walk at 11 o'clock on a Saturday.
We have them at all times,
All
though.
times.
I mean, evenings, during the
We
week,
just did one
mornings
at the
during the week.
library in Lindenhurst. They did a walk. The library patrons wanted to go on a walk, so.
It's really very customizable to your needs. So if that's interesting to you, definitely reach out to us.
Basically, Brooke and I are always working, if you haven't noticed at this point. We let her walk in the pouring rain, and I mean, it was a monsoon, and we walk rain or shine. That one we probably should have canceled. Because the doctor showed up.
Hindsight, 2020.
A pregnant doctor showed up.
Oh, God.
She did. And a few AARP members, but no community members. So we took the picture of us standing in the rain with the umbrella, and you know what? We used it to push it out on social media. Walking is so important, you should do it rain or shine. Right. And then Brooke and I went to breakfast there. Because I felt bad dragging her out.
Okay. And then just two other items. Keep Long Island covered. I don't know if you want to give the background on that, but we have stacks of flyers in the back of the room. If anyone would like to take them to distribute to their clientele, that would be wonderful.
And I'll give a background to this. So this has to do with rights. I know, it's almost time for Tom. I'm gonna shut up, Tom. I'm almost done. when the pandemic ended, right, and for 3 years, you did not have to recertify for Medicaid and CHIP. That's over. Now people have been getting notices, you have to recertify. Some people will still qualify and some will not. So we have, we're a subcontractor on a grant from the Community Service Society of New York, right?
Yes.
To do an outreach campaign, which we're very good at doing. So and we're doing it in partnership with the Health and Welfare Council of Long Island and the Central Nassau Guidance and Counseling Center. We want to reach people, as many people as we can. There's like 900,000 people on Long Island that need to be reached to make sure that they recertify so they don't lose coverage. So again, if you are so inclined, we have stacks, both in English and Spanish, stacks of flyers, just like you see up there, that if you would please take and maybe distribute to your constituents, if it makes sense for you, we certainly would appreciate that.
And they are also in Haitian Creole upon request.
Haitian Creole.
Oh, I love that. Yes.
Yeah, we'll
Yes,
definitely- I can
quite
print
a
someone
bit.
here, definitely.
Yes. And then the council will be doing a flu vaccine and COVID booster social campaign. And maybe we'll throw an RSV in there too, the trifecta. Because do you know you can order 4 free tests per household from the government of COVID tests? Yeah, so that's good because we've moved to commercialization of vaccines and everything, so it's not necessarily free anymore. Anyway, so that's that. So Tom, you've waited so patiently. Tom is going to talk to us about HealthX, which has been around for a while. It's a combination of the previous RIO, which is the Regional Health Information Organization, that was here. It was HealthX, and then I think it was New York Information Gateway, also on Long Island. But now they're one, and Tom is going to talk to us about the data and you're funded by the state, correct?
Well, thank you very much for inviting me. I'm really happy to meet you all, to be here. I also wanted to mention that I'm joined by a couple of my colleagues, Suan Bolano and Yelena Kaplan. And I might ask Yelena to chime in because she has a lot of experience with CBOs and behavioral health, which is part of what we're going to talk about today. Let me share my screen. I have a slide presentation to take you through. And let me know if are you getting the full screen view of this slide? Sometimes you don't.
Yeah, looks great. Looks great, Tom.
Okay, great. So before I jump in, can I get a sense? You don't all have to speak up, but I'd just like to get a sense of how much you know about HealthX and how much you know about health information exchange in general, because I don't want to, give you a chapter and verse if it's something you're pretty familiar with already.
Never heard of it? No. Never heard of HealthX. How do you like that?
All right. And
Wow.
are you familiar with the concept of health information exchange?
Yes.
Christine Duffy uses it every day.
Yeah, Christine uses it every day.
Okay. All right, great. That helps. So as Janine said, we've been around for quite a while. I started in 2009. It started just a little bit before that, but we've been doing this for a while now. What I'm going to like to talk about today is kind of like what's happening with us recently. So I'll go into that a little bit. I'm not going to spend a lot of time about health because I really want to talk about the work that we're doing in value-based care. And I'd like to get some feedback from you all about how we can better support the CBOs and behavioral health. And finally, I'd like to hear your input on how we can support understanding of health equity. So this is our kind of mission slide, and we are funded by the state government to a large extent, but we're also a private not-for-profit, and we have our own sources of revenue. We're independent, we're certified or regulated by the state. We have to do certain things to maintain our accreditation as a New York State HIE, but we also have some independence here. But I think what I wanted to say on this slide is that we've in the early days of our organization really been about technology, about connecting hospitals and nursing homes and behavioral health and all these different types of organizations all together and having one big health information exchange repository. And that's a really challenging job, recruiting people, getting them signed up, getting them connected, making sure they're sending all this data. But we've been doing that now for such a long time that our focus is beginning to shift. And we're trying to be more of a community organization. We're still an information provider. That's our core competency. We don't provide care, but we're looking to be more involved with organizations like this to understand what are the information needs of the community and how can we work more closely with you. We have this data, but it's not necessarily put to the best use or as much use as it has potential for. So part of what I wanted to do today is find out what more can we do with all this data, all this information we have that would help the community and the kind of work that you do. So these next couple of slides are just kind of like our profile. We're really, really large, as you might imagine. We cover New York City and Long Island, so there's lots of people, more people getting care in our area than living in our area. This 20 million is actually probably a little low, and that's only the last couple of years that with all the people who have come and gone from Halifax, the number of records we maintain is actually closer to 50. These are the sectors that we serve. Clinical care is kind of how we started with the hospitals, but now we're starting to do more with population health and the health centers that I'm going to talk about in a little bit. Public health, the New York Department of Health, Nassau, Suffolk, State Department of Health are all customers of our people who we have. It's a very important part of our mission is to support their needs. We do a little bit of work with research. We'd like to grow. A lot of potential to use our data to understand epidemiology and what's going on with long COVID and mental illness and all kinds of interesting studies that we're approached for. And we also do a little bit of work directly with consumer. People applying for life insurance are able to get their records and more quickly qualify. We're also launching the patient portal in just a few weeks. That'll be really exciting. Anybody who can prove that they are who they are can have all of their information restored.
Tom?
Yeah.
I'm just going to interrupt you for a moment. If possible, if you could sit closer to your microphone. It's just a little, we can hear you, but it's a little bit garbled.
Oh, hang on. There may be, the setting may be wrong. Hang on a second. Sometimes it picks up the microphone on my laptop instead of on top of my computer. Yeah.
How's that? The better?
Yes. Yes. Yes.
Okay, that's what it was. Thank you for pointing that out.
Thank you so much.
Better.
Good. Yeah, so this is just a few of the areas that Halifax information is applied to. And this will probably continue to evolve over time. Okay, and then to put us in context, here we are in New York State. We're down here in lower New York State and covering New York City and the Long Island, but we have sister organizations all throughout the rest of the state as well. There's 6 of us all together.
Everything funnels up to the shiny, right?
Yeah, correct. So that's what this is about, really. So the State Health Information Network of New York, or the SHINY, allows us all to be connected to each other. So if a person lives in Syracuse and they travel down to New York for care, their primary care doctor in Syracuse can pull their records from HealthX into their local, and vice versa. But to be honest with you, most of the records come out of New York rather than come into New York because we're more of a destination for healthcare than other parts of the state. People don't tend to leave New York to get healthcare in other parts of the state. It tends to be the other way around. So then the other, of course, is our participants who are members of the organization and exchange data with us. And then we also have other HIEs. So Northwell, for example, is a very large system, as you know, and they run their own internal HIE. So we communicate with that as well. And then finally, on the lower right here, we are members of a national organization called Civitas, and that's where we get to talk amongst our peers all over the country who are doing the same thing and having the same kinds of challenges, which is really a rich resource for us. I'm going to just skip through this quickly, but this is if you wanted to know, like, well, what kind of data do you have and where do you get it from and how is it used? That all that information is here. You can, if you're interested in looking at this and studying this in more detail, I'd be more than happy to send these slides to you. And then this is another slide just to give you a sense of the volume of data. Millions of data records flowing into HealthX, millions of records going out electronically and through our portal. And we also, as you can see, deliver a large volume of care alerts. So these are the messages we send to people like a primary care doctor or a behavioral health group when they want to know that their patient is gone to the hospital. And this is just a little interesting story. During COVID, we all kind of went a little crazy at HealthX, like a lot of other people. And our focus was on helping public health to respond to the pandemic. And this is an example where we were able to help identify people who went missing during COVID. As you know, a lot of people were taken to the hospital and family members couldn't get a hold of them. And our service was enabled them to locate their loved ones. This gives you kind of a graphical sense of where we are. You can see we're pretty dense in the city and then quite dense in Long Island as well. And in the lower right here, an idea of the types of facilities that that are participating in HealthX. And all this information, by the way, is on our website in some detail. So I wanted to move to the main topic here, which is the work we've been doing recently to support value-based care, which is a big focus. We just had a conference yesterday on this topic, and it went really well. And the engagement subscription to that conference is a clear indication that this is a hot topic on everybody's mind. It was a great discussion. We, for our part, have identified the fact that we need to, as I alluded to earlier, need to do more to get the information that we have into the hands of people in a way that's really going to have an impact on the outcome, the care of their patients, and the efficiency of their operations. So I'll give you a little bit of overview of what we did. So we talked to about 20 different FQHCs and in New York and Long Island to understand what their information needs, and particularly in the area of value-based care. What is it about? What are you trying to accomplish in value-based care for your Medicaid population that you're not able to do as well as you'd like to? How can we help in that area? And a result of that, we came up with a bunch of analyses and reports, which I'm going to demo to you in a minute, of the things that are the highest priority to them. The goals of these reports from the feedback we got from the sites was to improve quality measures, HEDIS and UDS quality measures that financially impact them. Improving the outcomes of their patients by identifying people at greatest risk, and to also reduce inefficiencies, because they spend a lot of time trying to find people or follow up with people who need primary care, only to find out that they've already been taken care of by somebody else. And that's a huge waste of their time. We can tell them when that's already happening and avoid that extra work. And as you might imagine, our focus is to tell you about things that are going on with your patients outside of your organization. That's really where we come in. You theoretically know have a pretty good idea what's going on with the patients who you see regularly, but what about when they go somewhere else? And that's sort of where our focus is. Identify those high risks, and then everything that we do pretty much in real time. Message comes in, and if it's of importance, the message goes out. This is the product that we ended up with. We called it Focus 360. That's a kind of a double meaning there, because focus and 360 seem like opposite things, but what it really attempts to do is look broadly across the whole population, but then to focus in on the one thing that you need to know about a particular patient. And so that's where we come up with the name. I'm not going to spend a lot of time on this marketing material, because I'm going to give you a demo in a minute. These are the quick listing of the measurements that we the reports that we provide. There's two major categories. It's what we call the 360 view, which is, again, looking for care outside of your institution, and there's a lot of variations on that. And then the quality measures that are important for maintaining the best care for their patients, but also affects how they're rated in their performance and their financial reimbursements. And then there are a few others as well that I'll go over in the demo. Before I go to that, are there any questions so far? I know that was kind of a lot of kind of rapid fire of information. Okay, so let me go over to here, and this is the landing page to this dashboard of information. Again, this is all based on the analysis we did with the 20 FQHCs that we interviewed. And at the top here is information, general information about the facilities, how many males, females, the age span. Here's your guy who jumped on a horse at 105 and rode off into the sunset. Maybe he's went to this health center. And then how many people went to the ED in the last 30 days. And then a very important thing for anybody in HealthX is consent, because we can't show very much information about your patients elsewhere unless they've given you consent. So we keep an eye on that. And this allows them to find out, where they have to do a better job of collecting consent. So the 360 view is, sorry? The 360 view is kind of the cornerstone of this, and it's one report, one layout of information about your patient's care elsewhere. But through our analysis with feedback we got from the FQHCs, there are many different slices of that. So the first one is just all of your patients, all patients who had encounters elsewhere in the last month, 2 months, a week, whatever time span you want. But they also said, well, we would like that filtered by just the people who are high utilizers. They go to the hospital a lot. People who have had a referral, did they follow up and fulfill that referral? Did they present at the hospital for an STI? For the people who work with the people with disabilities, have they had surgery for dental care? Have the children received mandatory disability screening? And have they been to post-discharge care after hospitalization? So I'll just show you as an example. Oops, I logged out. This is by the way, this is all demo data. None of this is real. They're fake patients and so forth. But these are a listing of the patients who've had care elsewhere from this facility. They give the name, date of birth, when the encounter happened, what type of encounter it was, emergency, inpatient, outpatient, where it occurred, and if it's available, the diagnosis that occurred in that encounter. And then over on this side of the screen, we provide their demographic information. We've excluded phone number, not because it's not there, but because it just is part of the de-identification that was easiest just to leave it out. Any information that's in this report can be exported just by pushing this button, and it comes down to the local computer so they can do their own analysis. But we also have the ability to filter it here So you could, when you run this report, it defaults to 180 days, but you can do just the last week, for example, or you can pick a particular time period that you're interested in, like yesterday, if you want to do. And then in addition to time period, they can pick an age group of interest. These are the spans, which specific gender. They can pick any combination of these. So we could pick this age group for women and Asian and non-Hispanic. So that would be, that's a set of filters, and you hit apply. And oh, I picked something too narrow. So maybe I'll just eliminate that. Let's see if that, no. I think I picked it for the last 1 week, so that's probably too restrictive. I could make it a little bit more time. That might, yeah. And again, they can still export a filtered report as well. I'll go back to the home screen, and I'm not going to show you all of these, but another variant that people are interested in is the high utilizers. These are people, so you can see here, this individual has had 1, 2, 3, 4, 5 visits, and they were, looks like all of them were at NYP Cornell, but sometimes you see an individual who's been to, this one's been to Mount Sinai, to Harlem Hospital, and to Elmhurst, and to Elmhurst again. So these are people using the hospital quite a lot, and you can drill into these records by clicking on their name, and then you can find out if you want to know a little bit more about them. Here's their diagnosis information, all of their encounters, procedure history, lab history, etc. The other thing that you can do here is you can dial the utilization up or down. So I could say people with more than 4 encounters in the last 30 days. And that would be a shorter list. And you could focus on just ED and be shorter still. So that's the high utilizer version of the 360 view. And then we have one focused on HbA1c results. I'll just point out one thing about this. The HbA1c is flagged as being pre-diabetic or diabetic or severe or escalated or critical or whatever, but the one that I thought was most interesting is uncontrolled. These are people with very high results, and the interesting, not so great thing about this is that a number of these people are not diagnosed with diabetes. Most of them are, who go through the uncontrolled, most of them are, but occasionally you run into people who are not. All right, and I guess I think that's probably enough of this, unless you have any questions, if there's any area that you're particularly interested in.
There's one question in the chat, and it might be some cost involved. How do we get to this? How does a CBO, how does a community-based organization get to that platform?
So right now, we're just launching this for FQHCs right now. And we worked out a deal with we have a vendor who did the development for this, and we worked out a deal with them where we were able to offer it at a very affordable price for the FQHCs. We're also, this may be a good time for me to segue into back to the slides here. Because that's kind of what I wanted to talk to you about. So this is going out to the FQHCs in October. After that's been, we're going to start that expansion, but we're also have plan to start moving this on to IPAs and ACOs. We also have a proposal pending to expand this service to CBOs and BHOs. Now, what I was hoping I could find out from you all is what parts of this, if any, would be useful in the context of CBOs and BHOs, because I've had some help from Yelena, who has quite a lot of experience with CBOs and BHOs. But if we are awarded this grant, we'll go out and interview people, and we'd like to get it in a lot more detail. But to answer the question about cost, there are fees for the FQHCs. There will be fees for the IPAs and ACOs, but in the grant for the CBOs and BHOs, we decided it would be no charge. We'd offer it at no cost. If we're awarded, we'll offer it at no cost.
That's great to hear. CBOs here, how would you utilize this? Like, what would be helpful for you to utilize in this, what he's showing you?
Excuse me, I have one question. This data is only for individuals that have health insurance and have had medical visits. For example, individuals without health insurance will visit the emergency room several times in different areas and so forth. Do we keep data on that, or is it just through health insurance?
Health insurance has no bearing on what data is included. The data comes to us from hospitals, physicians, behavioral health, nursing homes. Almost all of our data comes from clinical settings, about 8,000 facilities in New York and Long Island.
And the question again, when I had asked you some weeks ago when we initially spoke about getting patients to agree to share their data, it's not so much, I'm going to clarify this, it's that the data, when you go for an encounter, it is captured. What you're being asked at the physician's office is if you're going to allow your doctor to share that with HealthX.
Well, it's the doctor doesn't get to decide. The patient gets to decide whether they want to share it with you.
What do you mean, share it with you? Like, share it with the doctor?
Well, whoever's with the patient, whoever wants to get access to that information. So if you're the patient's doctor or care manager or social worker or whatever your role is, if you say to that patient or client, I'd like to have your information from HealthX, and they grant or deny that.
So what I'm saying is automatically the patient's information goes to HealthX.
Correct. Correct.
So when we're asking, because this is what was confusing to me, so when we're asking the patient to sign that form, and you've all seen that form when you go to the doctor's office, it's to allow the doctor they're dealing with
Correct.
to see the HealthX data.
Correct.
See, I
Exactly right.
thought that you as a patient had to approve whether or not you wanted to be part of HealthX. But Tom says, no, we're already part of HealthX if you're going to see a doctor or a hospital that has a contract with HealthX.
Correct.
Like the information.
Exactly
This
right.
is Chris Duffy. I at St. Mary's. I can tell you how we use it if that might help.
Sure.
So every day I open up my HealthX clinical portal, and I can see which of our patients have gone into the emergency room or the hospital.
Mm-hmm.
And we teach all of our home care nurses to ask patients for their consent on their first start of care visit. And then we bring that back and we put that into our EMR that they have consented, and we keep their consent uploaded on file. And that way, if they do go in the emergency room and I get an alert, I can go in to their record and see a little bit more information about why they're in the emergency room, only if they've consented. I can see the alert regardless of their consent, but if I want to learn more about, well, why did they go into the hospital? which doctor's treating them. If I want to potentially get a discharge summary, I can do all that in the portal if they've given me consent. And it helps us because we have, 1,200 patients and our nurses are tracking so many at once. We can let that nurse know your patient just went to the ED and they can call the family. And perhaps we can change the schedule and that nurse can get into the home quicker. Maybe she didn't have a scheduled visit for 2 weeks out, but now that he's coming out of the hospital, she'll reschedule the visit and make it for the days of discharge or the next day. So it helps us more in real time. And a lot of times patients forget to tell us they've been to the emergency room for something. Maybe they go in over the weekend. And again, maybe our nurse isn't scheduled to see them for another week or two. And by the time she gets in, they completely have forgotten that they had an ED visit and why. And this way she can educate. And another big thing is if their medications are changed, the nurse has the ability, knowing that, to re-educate about all their new medications. So those are just some of the ways we use it. I'd like to get more. We don't really get a lot of reporting and get into data analysis, and that is the next step that we'd like to do.
Great. And is St. Mary's, what type of organization are you?
We're post-acute care, so we have home care, but we're all children and young adults.
Okay.
And then we have our nursing facility in with 124 beds, and we have 500 children and young adults in our care coordination agency through health homes.
Okay, great.
Tom, trying to make the connection with the CBOs, Mora Foundation, can I use you as an example? Like, how would the Mora Foundation, which is breast health education, like,
it's hard for us because we're on the prevention side, so we're not dealing with a lot of clients but my old hat was working with people with head injuries. So if I was a case manager doing head injuries, of course, I'd love to know that my client was hospitalized, right? So that I can be able to help make sure they're getting the appropriate services when they're coming home. So I can certainly see, and on the mental health side, I can certainly see providers wanting that as well, right? To be able to provide follow-up. So I think the information is amazing. To be able to get access to. It's just currently with our organization, it's not a good fit for us.
That wasn't a good example.
What I would like to see, I'm sorry to interrupt, is that if there was some sort of barrier assessment component, like when people go into the hospital and they get services through a social worker or something like that, I would like for our organization, that would be helpful. Like what they spoke to the social services person about. What was their referrals? Where did they follow up with their referrals? What other services did they recommend that the patient didn't know about or was aware about? Because we kind of do that sort of thing. So for us to not step on each other's toes, I would like to see that whether or not they received emergency Medicaid in the hospital would also be something that we would, like to see, that kind of component, because we are on the prevention side as well. But we also do, in order for us to be preventative, truly, we have to take care of those things that are preventing people from having adequate access to healthcare, such as transportation, affordability, being able to know the services are out there, and barriers to access and insurance, all those other things that can be preventative from having true access to healthcare, because, life happens to everybody. So that's how we deal with preventative care for us. So that would be a kind of thing that would be helpful for our particular program.
So the first thing is that they would have to have a contract or be connected to HealthX. No, I'm confusing. You're talking about.
So if because we are Northwell, so if Northwell has access to this, in order for us to be able to use it, we would have to have that kind of component as a.
So you want more measures in there?
Yes, that makes sense for us in dealing with preventative, because people go to the hospital for many things. I mean, I just went to the hospital because I had to have surgery, and obviously I'm sitting here working today, so it's just like a little hiccup in the road. You do what you got to do, but also, I would like to see, like, if I'm going to do that, because, you know, God forbid you fall off a curb and you know, sprain your ankle. You may walk out of there fine, you just want to check it. We would like to know that. And then if you're already sitting there and you're already talking to someone, you're more open to, you know, kind of take advantage of the services. So whatever is going on in that visit that could potentially be, you know, beneficial to us, we'd love to have that.
So you're interested in social determinants of health as well? Yeah. So, you know, Janine was talking about the waiver coming, and this is something that we're really, really dialed into. And if or when the waiver is passed, there will be a mandate for all healthcare providers to send their referrals and screenings to the Shiny via their HIE. So once that goes into effect, first of all, they're all going to be, a lot of them are doing it now. A lot of them are doing assessments and screening and referrals, but they're going to be required to do that more, and they're going to be sending all of those to us. So once that gets settled in, it'll take a while to implement and so forth. All that information about social determinants of health will flow into Healthix and the other HIEs, and we could use it for this type of reporting.
Okay.
Yeah, it may have just been sort of covered a little bit, but I see us using it in preventions just, you know, in terms of vulnerability data, specifically what drives, we have 10 categories where we right now source census data and don't have local data to by zip code for the things that are predictive of mental and behavioral health disorders and by specific age group. And then on the other end, looking at prevalence data, you know, obviously the idea of prevention is to see those numbers go down. And so having a pulse on that and having reporting features on that where you can, you know, consistently see those fluctuations, especially if you're working in a specific community to reduce those numbers, is really, you know, really helpful and hard to access kind of census level data because it only comes out once a year, sometimes once every 5 years.
Great.
Okay.
Well, we've run over a little bit, and I've got to, I'm late for another meeting, but I again, I really appreciate your inviting us in and giving us a chance to talk about this. Would love to invite any other input on how we can help with healthcare in general, but specifically with the CBOs and BHOs.
Okay. Well, thank you, Tom. And
Thank you.
I'm sure I'll be following up because I'm still not 100% got a clear view of how this all connects, but that's a conversation we can have together.
It's a lot. We have to go through it a few times.
Yeah.
We do that all the time, so no problem.
Okay. Thank
All
you
right.
so much. Thank you. Thank you,
Take
Tom.
care. Bye-bye.
And we did run a little over, and I apologize. 2 hour meeting's a long meeting, but a lot of people hung on and stayed with us, so thank you for that. Next meeting is December 8th,
I believe.
It's hybrid again. Well, it's hybrid again.
And of course, we'll send
Everything
reminders.
out.
December 7th, excuse
December
me.
7th. Okay, December 7th. It's always on a Thursday, I think.
Yep.
We'll send information out again. In between, we'll be connecting with the core clusters.
Yes.
I'll have more information about what that.
And Janine will be joining us.
And
at the
I'll be
core
joining you
cluster
because
meetings.
yes, I'll be able to join the core clusters. And we'll move forward from there. And I hope 2024, in all respects, is a totally productive year and a great year, and every which way possible. And at the December meeting, maybe we can have a little bit of holiday fun. We'll see.
Very nice.
We'll see.
Thank you all for being
Thank
here
you so much for
virtually and
hanging
in
out.
person.
Take some